So, welcome everyone today on the 20th of August, a very wonderful evening. As the title very rightly suggests, this is the mixed bag in association with YTP Committee Foxy, where we have the North, East, West, and South, the best of all, to talk on endometriosis and abnormal uterine bleeding. So, first, this is brought to you by Bharat Serums and Vaccines under the Bridging Bharat initiative. So, first, I would like to pass across the con to Dr. Priyankur Roy. Dr. Roy,
Yeah,
before kindly take
thank you,
it ahead.
session. Thank you, session, for supporting this session of ours today. It's a session on mixed bag, and I welcome all our distinguished faculties, all our viewers present with us today. So it's a session on mixed bag that we're having today evening, and we are presenting it in association with the YTP committee of Foxy. It's a great start to the program because we have almost 1,000 plus viewers who are with us today, and I welcome each and every one of you present with us today. So first of all, I would like to introduce my co-host for today's evening, that is Dr. Indranil Datta. Session, can you please play the slide, please? Yeah, so Indranil slide. Yeah, Indranil is basically, he's a very good friend of mine. He's done his diploma in advanced laparoscopic surgery. He's a fellow in ultrasound, endoscopic surgery, infertility, gynae oncology. He's an associate professor at IQCT Medical College in Durgapur and an East Zone coordinator under Alpesh Gandhi sir. He's a past president of the Kalyani Obs Gynae Society and the secretary of Indian Academy of Obs and Gynae. He has published 39 articles in various journals and written a number of chapters in various textbooks. So over to you, Indranil. And he has, of course, won a number of awards, out of which the most prestigious being the Shanis Ratnam Award in EOFOG, which he received in 2017. We are really privileged to have Alpesh sir, Narendra sir, Hema ma'am, Bhaskar sir, Ramani ma'am, Kavita ma'am, Atul Ganatra sir, Archana Verma ma'am, Sunil Shah sir, Priti Kumar ma'am, Niharika ma'am, and among other panelists who are present from various parts of India. So I welcome each and everyone to this program, and we hope we have a great session and great discussion today evening. Over to you, Indranil.
Yeah, thank you, Priyankur. And I would like to introduce my co-host for the day, Dr. Priyankur Rai. So Priyankur has done his fellowship in infertility and gynae endoscopy, and he is a consultant of infertility and endoscopy in Genome Siliguri. He is also the Indian representative for TOG at FIGO. He is the East Zone coordinator for Perinatology Committee as well as the Infertility Committee. He has been the recipient of various awards, including the Shanes Ratnam YJ Award, which he received last year in Philippines. He has delivered Taminira orations and has published more than 50 articles and papers in various national and international journals. And he is also the organizing secretary of East Zone Yuva Foxy 2020. So we welcome all the seniors and all the esteemed Foxians and Hema Madam, Narendra sir, and Atul sir, and Bhaskar sir, and especially Alpesh sir for accepting the invitation on a short notice. And with this, I will hand over the mic to Priyankur to introduce.
Yeah. Yes. So first of all, I would like to introduce the guest of honors for today's evening. And first in the list is Dr. Alpesh Gandhi sir. He's everyone knows him, and I don't think we need to introduce him especially. Just a brief introduction of him. He's the president of Foxy. He's done his hospital management from IIHMR Jaipur. He's a governing council member of ICOG Foxy in 2016 to 17, chairperson of the Practical Obstetrics Committee 2009 to 2011, vice president of Gestosis India chapter, convener, one of the most successful AICOG 2017 at Ahmedabad, past treasurer of SOGOG, member of the PCPNDT Ahmedabad district 2005 to 2008. He has received the RCOG award with the honorary FRCOG and founder admin of the biggest social networking of Foxians on Facebook. Sir has just yesterday we have finished an excellent program. He's basically a visionary president, and we have done excellent program on training the healthcare workers on COVID, and there were almost 12,000 healthcare workers who had joined from all over India. So there are excellent programs that are going on, and I welcome you, sir, and congratulate you on the excellent success of that program. You and Preeti ma'am, both of you, for the excellent success of that program, sir. So over to you for a few words, sir.
Thank you very much, Dr. Priyankur, for the kind introduction and kind words. Dr. Narendra Malhotra, Dr. Hema Divakar, Dr. Ramani Devi, Dr. Atul Ganatra, Dr. Kavita, Dr. Archana, Dr. Priti Kumar, Dr. Sunil, all the esteemed faculties, and dear Foxians, dear viewers, a very good evening to all of you. And I would like to thank Young Talent Promotion Committee for inviting me and giving this honor. I would like to congratulate Young Talent Promotion Committee for excellent work. I can see so many programs, so many publications. They are continuous. All the team members of the Young Talent Promotion Committee are very active and vibrant committee. So I congratulate Dr. Niharika for the excellent work. One more reason to thank you, Young Talent Promotion Committee. This is the committee which is active in all the Community Connect program of Foxy. We have conducted so many Community Connect program. We have conducted CSR activities, all CSR activities, scientific CSR activities which can bring impact in the society, and our vision is to take Foxy's name, Foxy's vision, Foxy's brand, Foxy's good work to each and every corner of India and to each and maximum possible citizens of India. And I am happy that in this month also we conducted 3 big Community Connect program. On 7th August, we conducted a program on breast promotion, and in which we could reach to 52,100 mothers or women of India. So it was beyond our expectations. Second program, which was conducted on immediately after 2 days on 10th of the August for the celebration of World Youth Day. And in this program also our target was to reach minimum 1 lakh boys and girls. I think before installation, I talked to Dr. Hema that this is one program, if she remembers. So I told her that at that time also, okay, we are aiming to cross 1 lakh. And in Lucknow conference also, during managing committee, we discussed about this. And I'm happy that in spite of this COVID-19 time, in spite of schools, colleges are closed, and in spite of all youngsters may not have, particularly in rural area, may not have the internet access. In spite of all this, we could reach to 1,25,000 boys and girls of adolescent and youth. And more important is we have received 10,000 questions. So that this shows their trust, their faith in us. They want to communicate with us. This shows that they have found some platform with us where they can communicate with us. Of course, it is not possible to accommodate or address all those questions. So we declare that we are going to come out with frequently asked question booklet. From this question, from these questions, we are going to select few 500 to 1,000 questions, and then we are going to come out with a book on preventable adolescent healthcare education, and which this book we are going to upload not only on our website, but we want to send it to all the schools and colleges across India wherever is possible. At least those those 1,500 school colleges who have participated in this program. So, and next, then recently, yes, with Safe Motherhood Committee, we conducted one more program recently. Just yesterday, it has completed. And again, it was a Community Connect program. It was a program with our paramedics. We during Lucknow conference, we declare our theme. That theme is safety first for women of India and Foxians, and safety of Foxians automatically includes safety of our members, safety of their hospitals, and safety of their staff. And we believe that in this COVID-19 time, it is very, very important to train them, to update them, how to take care during this COVID-19 for the safety of patient as well as for the safety of our paramedics. And when we believe that when our paramedics are safe, we are safe and our patients are safe. So it is very, very important to train them. And to our surprise, initially we declare for the 5,000 paramedics, but we have to increase the limit because of the overwhelming response, and ultimately it turned to be 11,000, more than 11,500 paramedics. So we could train 11,500 paramedics in a day, and with the help of WHO and AIMS Delhi. and we have received many good positive feedbacks from all of them. And again, we have received so many questions, and we are going to come out with the FAQ book for the paramedics also. So this could become possible not because of me or a Safe Motherhood Committee single or us only Foxy office bearers. This became possible because of the support of 260 societies across India and all 27 committees of Foxy. And I am thankful. Let me take this opportunity through this platform. I would like to thank all of them, all 260 societies, all 27 subcommittees, and all 38,000 Foxy members for supporting Foxy's vision, Foxy's programs, Foxy's activities. Once again, I would not take much time, and I congratulate Young Talent Promotion Committee for coming out with this interesting webinar. Two interesting topics we are going to discuss: endometriosis and AUB. Both are very important topic, and I can see a galaxy of speakers. Those all are experts of their subject, and as Dr. Priyankur has announced that more than 1,000 delegates are there. It's really a achievement. I wish grand success to this webinar. I wish happy learning to all the viewers, and I wish safety to all of you. With this, I hand over to Dr. Priyankur and Dr. Indranil. Thank you very much for giving me this opportunity to connect and communicate with all of you. Thanks a lot.
Thank you, sir. Thank you for the wonderful word. And sir, in spite of the COVID pandemic, you have shown the way that how the programs can be kept alive and how everything can keep going forwards in spite of such problem that we are confined to our homes. So thank you for being there with us. With this, I would like to introduce our next guest of honor. So Shishan, can you put up the video? Yes. So he is a well-known figure in the Foxy world, in the IMA world, in whatever world you can call. He is the most prominent person and the most dominant person in the online or the offline field. Sir has shown the way to many youngsters, including me, and has been an inspiration to a lot of people. So with this, I would like to introduce Professor Narendra Malhotra, sir. So sir is a professor at the Dubrovnik International University, and he is the past president of the ISPAC. Obviously, he is the past president of the Foxy, which he held the post from 2008 to 2009. He is also the past president of the ISAR from 2016 to 17, vice president of the CEFOG from 2019 to 21, member of the FIGO Guideline Committee, dean of the ICMU in 2008. He is also the director of the Anne Donald School of Ultrasound, which is quite famous, particularly for the youngsters. And he is the managing director at the Global Rainbow Healthcare Agra and the director of the ART Rainbow IVF Center in Agra and Delhi, where in Agra I have been personally there, and I have seen how much hard work is being done there. With this, sir, I would like to hand over the mic to you, and thank you for being with us.
Very good evening to all of you. Thank you very much for inviting me to this interesting webinar on endometriosis and AUB. As we said, every disaster, every difficulty offers a new opportunity. And this disaster has shown us a new opportunity. First 3 months, when we were in complete lockdown, we cleaned our planet Earth. So the ozone hole closed and the pollution decreased and the rivers cleaned up. And now when we are opening up or not yet open up, started the electronic connect world. And it is so good to be electronically connected to everyone. Never we could have ever thought, even my physical, that we could have touched so many lives and so many people at a time and connect with so many of us. So we have practically reached each and every society and each and every member of Foxy, those who are interested. Those who were in the beginning not interested, fed up with webinars, are all joining back again because they're feeling the loss of that connect. So this has given us a new connect, which is very, very great. And congratulations to Alpesh. It is his and his only far thinking that led us all into this electronic connect world. And of course, all the Foxy office bearers, all the 27 committees, all the 250 plus societies, everybody is doing great work. We've all suffered Out of the 3,000 plus doctors infected with COVID, 202 have lost their lives. Today only two more have gone on ventilator in Lucknow. The virus has not yet gone away, but someday we have to say, COVID, so what? And today is the day when we have to say, COVID, so what? And we have to come out and fight this infection and learn how to live with this virus. So this virus has come, let's learn to live with it. As soon as the vaccination comes, we'll all get vaccinated. Probably by that time, 70% of us will already have antibodies. As a sero survey in Pune and Delhi shows that about 40% already are showing antibodies without even getting the infection or without, say, symptomatic. So that's a good sign, and probably this virus will die away. Probably this will remain with us forever. Probably this will come with us repeatedly. But whatever it does, we are going to continue our activities, our education, our conferences, everything online. So all the best, Priyankur and Indranil, for hosting this great subject, endometriosis, one of my favorite subjects, and AUB. And I'm sure we're going to listen to great things with Ramni Devi, who was the past endometriosis chair during my time. And let's hope we have good academics to everyone, to the 1,000 plus attending. All the best. It's been a pleasure here. I will have to take a leave after 5 or 10 minutes because to join somewhere else. Thank you for inviting me here.
Thank you so much, Narendra sir, for your kind words. And of course, it's a blessing to have you around, and you put in so much of energy to it. So it becomes really a blessing for all others who are also present here. Thank you,
Alpesh
sir.
wants to say something. Yes, Alpesh.
Thank you for allowing me in between. Before I leave, I would like to request one or two more requests to all of you. Foxy has Foxy has worked very prompt and proactively against this fight against this coronavirus, and we have started our national registry on pregnancy with COVID-19, and we are the pioneer. Even before ICMR registry, 2 months before them, we have published our registry, which is uploaded on our website. So I request all of you to please share the data in this registry. We have collected a very good number of cases data, and I can say India may be the first 3 countries having the highest number of cases in the registry, and probably we may be there in one of the 3 countries. Only we can lead to in world only and only when you all support, and we can get data across India from all the colleges, all the institutes, all the COVID designated hospitals. Then we can lead the world with highest number of cases, and we can be the example for the world how we can manage the COVID-19 pregnant woman. So we have some interesting observation also of this good number of collected cases. So this is my request, all of you, to please share your data. And one more thing is Foxy has declared 90 days for the anemia free India on the 15th of the August, and on 15th of the August we have decided to reach to more than 1 crore women of 1 crore listeners. And through radio, through 24 societies and through Radio City, we have crossed and we have reached to 1 crore and 6 lakhs. So Foxy is across everywhere. So with Foxy's name, Foxy's song, Foxy's jingle, and Foxy's theme, and Foxy's interview, we were there on the radio across India on 15th August. And this movement is going to continue. Different activities will be continued for 90 days. So let us join for this anemia free India movement also. Thank you very much for allowing me. Sorry, I would have to leave, and though I wish to attend these very interesting topics and interesting and experts, please allow me. Thank you.
Thank you so much for sharing your vision, sir. Really, your visions have taken Foxy and taken all of us like across India into the hearts of many women, I'm sure, sir. Thank you so much, sir. So moving on to the next chairperson for today's evening, it is Dr. Hema Divakar ma'am. Again, everyone knows ma'am. She is a very prominent figure in Foxy and elsewhere as well. She was the president of Foxy in 2013, consultant at Divakar Specialty Hospital, Bangalore, Foxy ambassador to FIGO, Vice Chairperson of the FIGO GTM Working Group, CEO and Chairman of Artist, Asia Research Training Institute for Skill Transfer, that's Artist, Technical Expert, India Institute of Public Health, Government of India, received the FIGO International Woman Achiever Award in 2015, ex-Senior Vice President Foxy, ICOG, and she was the Honorary Secretary, actively working with Government of India on research projects in rural India, and National Teaching Expert for Skilled Birth Attendance Training. I welcome you, ma'am, to this platform and request a few words from you, ma'am.
Namaskar. On my own behalf and on behalf of everybody watching this program, I bring very warm greetings to our President, Dr. Alpesh Gandhi, the present President and the present set of very distinguished office bearers whom I can see here, and also to the esteemed members of the organization who have held prestigious position in the past, in the present, and also it's very evident that we are seeing more and more of the future leads as well on the screen here. So congratulations for putting up this program together, rightly called the mixed bag. Okay. I must place on records what kind of a bag and thoughts are mixed in our president's head, that right from the insurance of the Foxy member to organ donation to adolescent to tree planting. Yesterday I just raised a question like, how do we connect? How did this, a thought process happen in your mind? Because it's right across all stakeholders, all strata, all everything, and the force with which it is happening. Narendra said, Corona, so what? So Dr. Alpesh Gandhi, from end of February when the physical meeting happened, I think he was one of the quickest ones to range from upset to set up, within fractions, and said, so what? And then there are so many programs that are rolled in. So that is a mixed bag indeed, which is being witnessed by every single Foxy member in the entire country. And I would like to congratulate just about everybody in our organization who has supported in times of the crisis where we often cannot think straight. And so well coined is the mixed bag today, because, ladies and gentlemen, the mixed bag is not only the mixed bag of the two topics of endometriosis and abnormal uterine bleeding. It's indeed a mixed bag of young talent, promotion, and the senior members and everybody in our organization mixed up all together as one big family. So it has been our vision to create many, many youth leaders in the country, and we want to step back into the position of thought leaders. So in keeping with innovative thoughts, both from the young and old, from the experienced and the novice, we would want you to lead the way to actually implement many of the initiatives for girls and women in this country to make an impact truly, which speaks of the vision and mission of our organization. So with these few words, wishing you one of the most brilliant learning experiences with Priyankur and Indranil. When Indranil was staying at my place for a short while in my guest house in Bengaluru, I had Dr. Datta visiting me and scolding me that you haven't given a cup of Bonvita to my son. So I said, I'm not in the kitchen department. He has to look after himself. So those were the days from where I know the duo, father and son, and my culinary skills. Everybody in Foxy knows what it is about. So it's indeed, life is a mixed bag, dear friends, and let's all get together to make a difference, to make this world a better place. Thank you very, very much for making me a part of this wonderful evening. Thank you.
Thank you, ma'am. Thank you for accepting our request. And I remember that 10 or 11 years back when I was confined I was there in your guest house, and my dad used to scold me day and night. What are you doing? Learn something from madam. Go and study something. So all the time I used to get, but it was nice to have you here, ma'am, and you really inspire us. And hopefully, we youngsters can do something in the line in which way you are working, or even all our seniors are working. So with this, I would like to, and really we are happy that ma'am is here with us as a guest of honor. Our next guest of honor is Dr. Bhaskar Pal sir, but sir will join us in a few moments. So with this, I'll move on to the first panel, and I'll like to introduce our chairperson for today. So it's the first chairperson for today is none other than Dr. Atul Ganatra sir. So sir is the vice president of the FOXY, and he is the treasurer of the IAG and member managing committee of the MOGS. He is very much approachable and very much compliant. And if you have any problems, you can always reach him over the phone. Sir, we are really happy to have you amongst us, and give us some time. So with this, I would like you to say a few words about today's program. And
thank you, Indranil and Priyankur. I think the earlier three speakers were stalwarts of FOXY. Dr. Narendra Malhotra, all the three past presidents, Dr. Narendra Malhotra, Dr. Alpesh Gandhi, who has given us sleepless nights, and of course Dr. Hima Duwakar, who has been my teacher since my undergraduate days. I don't know if she's still there, but Madam Namaskar, Dr. Kavita Bapat, and the entire group.
Namaste.
Thank you for inviting me. And indeed, Corona has, I think, brought, if not anything else, brought all of us together digitally. At least we see each other more often than we used to see each other in the earlier days when unless we went to conferences. Kavita is there. Kavita is the next pillar of the FOXY conference. And thank you very much for having me here.
Thank you so much, sir, for your wonderful words. You said that you were busy, and thank you really for coming and joining us for today's program, sir.
We've been jumping webinars, Priyankur. I think I just
I can understand,
one.
Of course, sir.
Yes.
Yes, sir. It's wonderful you're with us here, sir, today evening. Thank you, sir. Move on to the next chairperson for today's evening, Dr. Archana Verma, ma'am. Again, everyone knows ma'am quite well. Sana, can I get ma'am's slide, please? Yeah, ma'am is she is vice president elect in FOXY. She has worked on creating awareness on women's health. Special interest is infertility. She's the associate member of RCOG, director of Archana Nursing Home, past president and secretary of the GOGS, organizing secretary North Zone Yuva FOXY, organizing secretary of UP ISAR, midterm UPCOG, chairperson of the Public Awareness Committee FOXY as the ex-chairperson. She is the executive member of UP ISAR and UPCOG, member Rotary Lions and Udan BVP Awards. She has India Book of Award winner. She's the Presidential Best Committee Appreciation Award she has received. She has received the UP Governor, Uttarakhand Governor Appreciation Award from CRPF Director for Health Program 2019, Woman of the Year Health Award from Akanksha NGO, and faculty in 300 plus national and international CMEs, and of course more counting right now. So I welcome you, ma'am, to today's program, and really your smile and your enthusiasm brings a lot of energy to all of us, ma'am. So I request you to say a few words, ma'am.
Thank you very much, Dr. Priyankur and all. I am so excited to be here because 20 number as such is very frightening, but today is the 20 and I am just almost dying to be on this biggest platform of today, where Dr. Alpesh Gandhi has given us such a wonderful message, and Dr. Narendra Malhotra and Dr. Hima Diwakar and our dear Indranil. Born Vita to yaad rahega hame. And Dr. Atul Ganatra, very good evening, and I really wish Dr. Indranil the best. I think he's going to be the star, future star.
Thank you.
And Kavita Bapat, my dear friend, I can see both of us today. Thank you for inviting me, and I really wish the best panel is coming, Dr. Ramani Devi, and you are doing wonderful job as already told. Corona में मतलब इतना अच्छा सब कुछ और क्या expect कर सकते हैं आप imagine करो. Thank you, and please go ahead.
Yeah, thank you, ma'am. Always keep smiling like this, and we'll always like to have your blessings for all of us, all the youngsters. With this, quickly, I'll move on to our next chairperson for the day, is none other than Dr. Sunil Shah, sir. He is the Joint Secretary of the FOXI. He is the Senior IVF Consultant in IVF and Special Interest in RPL and RIFs. He is the Honorary Secretary of the AOGS Ahmedabad and the past VP of Ahmedabad. He was also the Joint Secretary of AICOG 2017, which was really a visual treat and even a treat for having the food, different variety of the food. Past treasurer of the AOGS. With this, sir, I would like to hand over the mic to you, and we would like you to say a few words.
Thank you very much for introducing me and saying kind words for me. Thanks a lot. I can see a lot of short words. Our guest of honor, Dr. Alpesh Bhai, Dr. Narendra Malhotra, Dr. Hema Divakar, our two program coordinator, very young, talented, Dr. Indranil Datta and Priyankur Roy. I congratulate YTP committee chairperson, Dr. Niharika, for conducting such a nice webinar. And we have a very two knowledgeable moderator for endometriosis and AUB, Dr. Ramani Devi madam and Dr. Kavita Bapat madam. And I can see a lot of stalwarts here, and there is a galaxy of panelists. So they will enrich us with their knowledge. So by this, I conclude my this short talk. Thank you very much for inviting me to chair the session of endometriosis. Happy learning to all of you. Thank you.
Thank you so much, sir, for being with us today evening. After the endometriosis, the panel gets over by Ramani Devi ma'am. I would request the three chairpersons of us to kindly comment on your critical comments plus your additions to the additions for our viewers. So with this, we move on to the first panel discussion of today evening, to be moderated by Ramani Devi ma'am. So ma'am, again, she is the vice president of FOXI, very close to us, and she's very senior and she's always been supporting us. She's a managing director of Ramakrishna Medical Center and Janani Trichy Fertility Center, won 10 gold medals during UG and PG period, a winner of Professor C.S. John Prize in 2006 and 2007 and 2013, chairperson of Endometriosis Committee of FOXI 2014 to 16, IMA National Best Secretary Award for the year 2006, Woman of the Year Award by Bharati Darshan University 2013, Woman Achiever Award by Citizen of Trichy 2015, Member of Consensus for Endometriosis in Asia Pacific region, Dr. APJ Abdul Kalam Award in 2016, and a winner of a number of other awards also. Ma'am she has published a number of papers and of course has delivered a number of talks, orations, etc. in various conferences of FOXI and elsewhere as well. She's elected as ICOG Governing Council member for the year 2018 to 20. And she's an International Advisory Board member for Endometriosis Society of Bangladesh. So I welcome you, ma'am, to today's forum. And I now request Indranil to kindly introduce the panelists, and then we start with the panel discussion.
Yeah. So, Sana, can you share the screen? So to introduce our panelists for today for the endometriosis panel. So beginning with Dr. Neelam Mishra, madam, she is the president of the Kanpur Obs and Gynae Society, director and chief consultant Obs and Gynae and laparoscopic surgeon at Shivani Hospital and IVF Center in Kanpur. Areas of interest is minimal access surgery, hysteroscopy, infertility. She is a member of the IAGE. She is also proudly awarded with the Nari Shakti Platinum Icon for contribution to women health. She has organized various conferences that include and organized panel discussion in FIGO also on the role of laparoscopy in reducing maternal mortality. She was also the organizing chairperson of the endosurgery in UPCG in 2015 and also endosurgery in 2018. We welcome you, ma'am, to the panel. So moving on to the next panelist for today is Dr. Anju Turiyar, ma'am. So she is the president of the Bhagalpur chapter of the FOXI, consultant gynecologist at the Matritwa. She is the chief medical officer, ex-deputy super of SDA Nogochia. She is a zonal coordinator for IAEC East Zone and the vice president of AOGS BJ, and she is a life member of various national bodies. And she has also participated as a speaker, panelist, chairperson, and judge in various national and state level conferences. We welcome you, ma'am. So to move on to the next panelist is none other than Dr. Meera Lakhtakia, ma'am. So ma'am is a consultant at Allahabad. She is the honorary secretary of the Allahabad Society, scientific coordinator of the national conference. She has been the scientific coordinator of the national conference of Bad Obstetric History in 2017, Scientific Secretary of the National Conference SAFMA, which was held in 2016. She is a former Assistant Professor at the Hind Institute of Medical Sciences, Barabanki, and Subharti Medical College, Meerut. She has been awarded as a Health Ambassador for exceptional work for girls and the women of Allahabad, and she has done exemplary work by the Adolescent Society. She was awarded in North Zone Yuva Foxy in 2017. She has been consultant for various NGOs also. So we welcome you, ma'am, to the panel. So to move on to the next panelist, yeah. So Dr. Seema Pandey, ma'am, she is the director of the Seema Hospital and the Eva Fertility Clinic and IVF Center located in Azamgarh, UP. She is the president of the Azamgarh Ops and Gynae Society, secretary of the UP ISPAT chapter, editor of the ISPAT newsletter. She was from 2016 to 18, executive member and the editor in the UP chapter ISAR, organizing and the scientific secretary of the UP chapter ISAR 2014, and she has co-authored and edited various books that include Foxy Handbook of Drugs in Infertility and Foxy Focus on Preterm Labor. So we welcome you, ma'am, to be with us in the panel. Then moving on to Dr. Rashmi Goel, ma'am. She is the senior obstetrician and gynecologist and laparoscopic surgeon, ultrasonologist and infertility specialist, and she is a secretary, Mathura Obstetrician and Gynae Association, member of IMA. She is the coordinator of the medical wing of Brahma Kumaris, the largest international spiritual organization of women. She is she has worked as a technical consultant at Urban Health Initiative under Bill and Melinda Gates Foundation for the slum in urban area. So ma'am has been is the director of the Rashmi Hospital and a senior consultant at the District Combined Hospital in Vrindavan. So we welcome you, ma'am, to the panel. So moving on, yeah. So Dr. Debashish Sarkar, he is a young gynecologist from Agra. He has done his diploma in advanced laparoscopy from Germany, and he is a fertility specialist and the director of the Morpheus Uma International IVF Center and the Sarkar Hospital, which is located in Agra. He has been the fellow of the Indian Association of Obstetric and Gynecology, fellow of the Indian College of Maternal and Child Health. He has done his clinical training in ART at Singapore NUHS and the Krishna IVF Vizag. He has received various awards that include Nimish Kilat Award in 2015. He has presented more than 35 research papers in national and international conference. And he has also been awarded as the best upcoming fertility specialist of North India at Economic Time Fertility Summit in 2020. We welcome you, Debashish. So with this, I would like to hand over the session and the panel to Ramani ma'am, because she is the moderator. Madam?
Yeah, I will start sharing my...
Yeah, ma'am.
So first of all, let me thank YTP committee, Dr. Niharika, and congratulate her for the very nice program today. And I thank the chairpersons for being here with us. And I should congratulate and thank Dr. Priyankur and Dr. Indranil Datta for arranging for such a nice program. And I wish Dr. Indranil success in his future election. And today, I think I have galaxy of panelists with me who are all very senior. I think they are going to impart a lot of knowledge and newer vision to this topic on endometriosis, which is very close to my heart. So I bring you greetings from the Rock City, and Lord Ranganatha's blessings be showered to all the youngsters in this August gathering. And well, let me pass on this. This is endometriosis is a riddle wrapped inside a mystery, inside an enigma, according to Sir Winston Churchill. Almost every woman has got a retrograde menstruation, but menstrual debris reaches peritoneal cavity every month. But then why only some women develop this enigmatic disease? Because to date, if you see the literature evidence, maximum number of papers have been published only in endometriosis. So we know that endometriosis is a mysterious disease where lot of things have to be explored. According to American Society of Reproductive Medicine, endometriosis should be viewed as a chronic inflammatory disease that requires lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. Once, if they are going to have endometriosis, then they are going to be forever your patients. So our aim is to minimize the surgical management and relieve them from their pain, promote fertility, reduce the recurrence, and improve the quality of life of the patients. So the signs and symptoms, very commonly, it is not only regarding the pelvic system, but also extragenital organs can also be affected, like lungs, brain, umbilicus, etc. And the I would like to say the symptoms of endometriosis, I usually say it is 7 Ds. The patient will have dysmenorrhea, dyspareunia, dysuria, dystasia, dysfunctional uterine bleeding, and diffuse abdominal pain and difficulty in consumption. Just you take only 2 or 3 signs. If they are present, symptoms are present in a patient, then we can surely say that even without an imaging evidence, the patients are likely to suffer from endometriosis. Now let us come to the first case with she is a 19-year-old girl who was referred to our hospital with a history of lower abdominal pain since 2 months, and the intensity of pain was so severe for the past 1 week. The patient had a low-grade fever for the past 1 week, and bowels and micturition were normal. How will you proceed with the case? Dr. Neelam, would you like to take up this? Yeah.
Yeah, after taking other histories about the fever, is how long she is having fever for the last few days. Then we'll all the investigation, including CBC and urine examination and all the investigation. We'll go for the ultrasound, of course, trans-abdominal or per rectal, because she's an unmarried girl. So I'll not like to do her transvaginal ultrasound. I'll do per abdomen or transrectal. And I would like to, in history, I would like to take the age, what was her age at menarche, and did she had pains since menarche? Then what was the intensity of the pain since menarche, or were the cycle were regular, or is there is any history of the premenstrual spotting in that, and any relevant family history in her sister or in her cousins we can take, and about the mother, is there any history of endometriosis in the family. Then
you have rightly pointed out what are the history that should be taken, and then premenstrual spotting is also a sign of endometriosis. It gives an idea that the child can have a endometriosis. And family history, very, very relevant, because the incidence of endometriosis
runs in family.
Yeah, more than 7-fold increase. Yeah. And then on examination also, you have rightly pointed out that the patient needs to have a general examination. You cannot go ahead with the general examination. So per examination should be done. So this was the finding. The per abdominal examination showed a vague lower abdominal fullness and tenderness. That was the thing. And rectal examination showed fullness over the right fornix and a mass was felt. Now, what will be the probable diagnosis that will flash into your mind?
Yeah, I will get her investigation after routine and investigation. I'll get her CA 125 done. Is it ultrasound on the ultrasound examination, per abdomen or per rectal examination?
Ultrasound picture which shows an adnexial mass with a low grade echoes, and there is a pericystic flow. So now diagnosis is?
Yeah, it may be endometrioma or something like ovarian abscess, but there may be some time when there's too much pressure, the endometrioma may leak inside the abdominal cavity, and that may itself cause of fever in this patient, which gives history. And there's no evidence of calcification at fat component, so it's less likely to go to abscess. I think it is most likely an endometrioma.
Okay, you have rightly pointed out. And the fever she has, probably you said it could be secondary to ovarian abscess. That is also one of the things we have to think about.
Counts, what about the counts of the patient, CBC?
Counts are slightly higher, elevated.
But
Okay.
they can high in the even endometrioma also
Yeah,
leaking.
even in endometrioma, it can be high. So do you want to, Dr. Anju, this is a question to you. And thank you, Dr. Neelam. And how would you proceed with this patient? You need any extra investigations apart from ultrasound? Dr. Anju, are you there? Dr. Anju is not there. Okay, then Dr. Seema. Dr. Seema, she is also not there. Then Dr. Meera, can you take up this question? Dr. Meera?
Yes, ma'am, I'm here. Hello.
Yeah, yeah. I know.
Apart from ultrasound,
okay.
the history and the investigations and ultrasound, we can go for visual examination by laparoscopy. That is diagnostic for this.
I'm asking you, putting forth one question. Do you need to do an ultrasound in an adolescent girl with endometriosis? Or would you like to have any other investigation which can clinch the diagnosis? Because right and left, if the patient's relatives won't agree for an adolescent girl to undergo any interventional procedure. Anybody wants to add anything else?
MRI
can be done.
MRI can be done, yes.
Yeah, MRI can be done. And Dr. Neelam had
marker for the ovarian tumor.
Yes. So, Dr. Sarkar, you do want to take it? Dr. Sarkar?
Yes, an MRI can be done to see any incidence of deep infiltrating endometriosis and any bowel involvement.
So, do you think what is the incidence of deeply infiltrative endometriosis in adolescents? Do you think
deep infiltrating endometriosis would be around 5%, 5 to 10%.
You are wrong here, because the actual incidence of deeply infiltrative endometriosis in adolescent goes up to 30% in the current study. See, some 20 years back, it was less than 5%, but now the current study from Korean and Chinese group, they are telling that 30%
right.
It is increasing. So, can you others switch off the mic? Dr. Neelam, can you?
We have to do other ovarian markers like beta HCG, lactic dehydrogenase, and alpha fetoprotein also to rule out any like germ cell tumor or any other tumors of the ovary. Because these findings can be, but CA125 is must in this case, and of course MRI will add the diagnosis.
So, actually, this patient had the serum markers done outside. You see what is the level of CA125? It's around 2,118. Dr. Meera, would you like to comment upon the CA125 level?
This CA125 level itself will not be able to give the correct picture. You know, we have to see the complete picture with MRI, with ultrasound, with CBC and finding itself. So whether she is specifically the case of ovarian abscess or mass or endometriosis, complete picture would have to be taken. So we will not like to go for laparoscopy at any cost.
Okay, so you have rightly pointed out CA125 alone is not sufficient, but this alarming level of increase in the CA125, we have to have something else in mind. Okay, so it could be ovarian endometrioma, or it could even be a malignancy. So actually, this patient was referred to me as an case of ovarian malignancy. So, and all the other ovarian tumor markers were negative. So then, as somebody has rightly pointed out, MRI has to be done, but the patient has undergone already a CT and she came with a CT result, and the CT result was also confirming the same finding what the abdominal ultrasound showed, that she had a right ovarian mass with a cyst with the low densities and no enhancing mural nodule and no calcification. So that means it's ruled out
the malignancy.
Both evidence of CT evidence as well as the biomarkers, they have ruled out the evidence that the patient is unfit for ovarian malignancy. Then what is the cause for such a high level of CA125? Dr. Sarkar?
CA125 can rise in endometriosis because of the inflammation it causes, and
to this level?
yes, sometimes it can.
So the most clinching
long-standing cases, it can.
Long-standing cases. Yes. So this was the laparoscopic finding because the patient, see the endometrioma has ruptured all over the peritoneal surface. You can see endometrial spill. So this shows this particular patient has had a rupture of ovarian endometrioma that is being the cause for that massive elevation of CA125. So the moral of the story is just with the simple elevation of CA125, don't jump immediately to think about ovarian malignancy. It could be a rupture because I came across such high elevations of CA125 in few of the cases with ruptured endometrioma. Okay, then everything is done. This patient had a very nice recovery. Post-operative recovery was there. And in this particular patient, anybody wants to do AMH level?
Before surgery and after surgery.
Pre-operative. Yes.
So before surgery, you have done a AMH level. Yes. It is quietly all right. Then do you think it is going to reduce? The AMH is definitely going to come down?
Yes.
Yeah, but it recovers after some time.
It comes down.
It recovers after some time.
Maybe now there are studies to show that the AMH level recovers after 9 months or even 12 months. So how will you follow this patient? Because this is a girl who is an adolescent girl with a ruptured endometrioma. So now we are very much bothered about her future infertility, and she should be relieved of the pain and she should be prevented from having recurrence. What is going to be your management?
We'll do CA125 and ultrasound after 3 months.
Strict follow-up will be advised first, ma'am. Strict follow-up for clinical features, pain development or any kind of fullness, once again notice, any kind of premenstrual spotting, regularity of cycles. We will have to put her on OC pills, to have her regular cycles. Any kind of history suggestive that she is going for recurrence will have to be followed up. If required, ultrasound needs to be done, and then AMH level, as you rightly said, after 3 months of the surgery.
So this was what I had done, CA125 after 3 months. It was just beautiful. It has come down to 35, and an ultrasound, it has come down almost a normal ovaries, and the patient was totally free of pain. Now how, like Dr. Meera has pointed out, how are you going to follow up the patient? You suggested oral contraceptive pills. Then how are you going to counsel the patient?
We have to counsel the patient that she has to remain followed till her marriage life, at least before every 3 monthly, then 6 monthly. And sometime when there is a pain, we can put her on even Dynagest like things in between, because continuous OCs sometimes.
Okay, Dr. Anju, can you tell me something about the recurrence, chances of recurrence in that particular patient?
And the first thing I tell my patients is
by COVID very high in this case. Even after surgery, there is 30% recurrence after
30%, yes.
And in case of after 5 years, there are 50% recurrence is there.
So this was one of the longest studies by Sanvi. He from China, where he had followed up the patients for 23 long years. So that means the chances of recurrence are going to be very high, especially in young girls. Girls have endometriosis, the chances of recurrence is going to be high. So how to prevent the recurrence? Meera has rightly pointed out that she would go for a oral contraceptive pill.
And ma'am, one more thing, that first year of follow-up has to be most critical. She just might be lost to the follow-up, and if she is lost to the follow-up and not adequate treatment is given, she will land up with recurrence faster than other people.
100% correct. So COCs you said, then again somebody said about Dynagest, and the is anybody wants to give GnRH analogs for this particular girl?
Not yet.
Not yet. Uterine enlargement. Only when we see any uterine enlargement, evidence of the adenomyosis, then we can give GnRH analog. Otherwise, I think Dynagest will suffice. And this Mirana will not advise because she's unmarried. For Mirana,
I would suggest the simple thing would be to just put her. She's just a young girl, to put her on OC pills. Maybe make her bleed in between, or maybe give her continuous, so that she remains with us instead of just thinking of GnRH right now, because it's a short history.
Yeah, GnRH analogs preferably no. But continuous oral contraceptive pills, you can give it, ask her to bleed once in 3 or 4 months. But any preference for dynages, anybody has? LNJUS, no. Probably if the patient is not compliant, if she doesn't have a compliance with the oral contraceptive pills, we can go for an LNJIUS, because we have a smaller version of LNJIUS called as, that is one thing where we can use it for 3 years. Skyla, that can be used, that can be inserted at the time of surgery. But can anybody suggest something? Dr. Sarkar, you being an IVF consultant, would you like to talk to her something about fertility preservation?
Yes, we can consider that. And we'll also like to put her on Dynoges. That is a good molecule to prevent recurrence.
Yes, what the evidence says. What the evidence says. Evidence is for Dynoges or for COCs?
The evidence says that Dynogest does reduce recurrence as compared to the COCs.
Yes. So this is again a very beautiful study, that is Visan study to assess safety in adolescents. So everybody is bothered about the long-term use of Dynages. So here it has been done in 21 centers across 6 European countries. And the conclusion is the methodology is from 3 years they have done, included 111 cases from 12 to 18 years and followed up every month. And they had proved that Dynages offers the best choice. So can anybody suggest, Dr. Anju, how long can we go for use of Dynages? Can we use it for 1 year or 2 years or 3 years?
It can be given long term, even 4-5 years it can be given. There's no harm, and especially when peritoneal endometriosis, beside ovary, there are endometrial deposits are on the peritoneal surface or on the uterus. In those cases, it is very useful, and we can give it for a long time, up to 4-5 years.
I pointed out that long-term use of Dynages, some of the countries, they have used it right since from the time of license that was given by that was given for even 8 years, 9 years they have used. Probably if the same patient has come to you only with the pain and there is no acute event like rupture, what you would have done? You would have gone for surgery, or would you have gone for a medical management? What would have you done? Dr. Meera? Meera, unmute.
Hello, Haji ma'am. Ma'am, sorry, just a second. I could not hear the question, ma'am.
No, sir. Same patient, if there is no acute event like rupture, if you find a girl having 6 to 7 centimeters endometrioma, would you still like to go for laparoscopy, or would you manage her medically?
Ma'am, I would like to manage it surgically. 67 centimeters. More than 7 centimeters. Include the capsule. Remove the capsule.
What
about Dr. Sarkar or Dr. Neelam? Any difference?
Yes.
Of course, give her
in an adolescent, we can try medical management for
can be given, yes.
some time.
Yeah, I personally feel adolescent girls should not be touched laparoscopically unless they have certain definite indications like this, like rupture or hemorrhage, or when you suspect malignancy. Otherwise, medical management for n number of years with Dynages will be sufficient. Then this is another study to show that whether you need to use, Dr. Meera was suggesting about continuous oral contraceptive pills. Again, oral contraceptive pills, when given continuously, it reduces the recurrence. So this is Professor Dr. Thomas Romer, who is from Cologne University, Germany, where he has treated these patients continuously with Dynages for a period of 60 months. That means nearly 5 years. and he says this is going to have an excellent result, especially in adults and girls with not much of side effects. Okay, so it can be given every day. 2 milligram effectively reduces the endometriosis associated pelvic pain and prevents the recurrence. So the take home message, I want each person to give one take home message from this case. Start with madam.
Any patient coming, any adolescent girl coming for pain in the lower abdomen, it should not be ignored. It's at least minimum ultrasound of the lower abdomen should be done. Not like this, this can happen every time in the menses. Any girl is coming which is because of that she's not able to go to schools and going for her education because of the pain. In those cases, we must get investigation.
Just a single line, madam, single word. No stories, only single word. Okay, Dr. Sarkar, so your message is you have to think about endometriosis when a girl comes with dysmenorrhea. Next, Dr. Meera.
Take the family history which points towards the endometriosis and look at the menstrual irregularities.
Okay. Then, Dr. Sarkar, third point, you have already mentioned managed medically. So, Dr. Anju, would you like to add up something? Dr. Anju?
The girls, I mean, the adolescent girls should be counseled properly. They should be asked to do some physical exercise, not to miss schools, and they should improve on their diet as well. And
so that will reduce the incidence of.
And the laparoscopy should be reserved only for pain and responding to medical treatment.
Responding to medical treatment, and follow-up is very, very important. This you have already mentioned. In needed cases, fertility preservation. These are the take-home messages from this particular case. Okay, shall we move on to the second case? Second case is a 28-year-old married since 5 years, infertile, cycles are regular. She is an hypothyroid on L-toxin, dysmenorrhea plus, history of dyspareunia, history of no history of family history of hypertension or diabetes. Past history, she has had a laparoscopy for endometriosis elsewhere, ovulation induction done 6 cycles, IUI 4 cycle. Now she has come to me with as she wants a baby and get rid of her pain. How are you going to manage if such a patient comes to you? So she is a case of previously operated for endometriosis, keen on ovulation induction and IUI failures. So
we will get her AMH done first. Her ovarian reserve, we have to see about her ovarian reserve because she's already 28 and we have to see her ovarian reserve first. What is her ovarian reserve? And what about the number of eggs in the ovary?
So before that, before going to AMH, when she comes to you in the clinic, would you want to do an ultrasound before ordering AMH?
Yes.
So ultrasound will be the first, because here in this particular patient, I wanted to bring about one point. The recurrence can be there, isn't it? Don't you think of recurrence because she's having persistence of dysmenorrhea and dyspareunia. So she is likely to have a recurrence. And one more point I will stress is these patients who are endometriotic patients who are undergoing repeated ovulation induction and IUI, instead of IVF, they are at a high risk of developing recurrence. So that is what the literature says. Okay. So
the examination is also required. PS and PB is also for her because
ultrasound, hormone assay, and assess the male factor. All these things I think you have mentioned.
125 is required.
Yeah. I'll come to that. So the normal, her ultrasound finding was she has a bilateral endometrioma now. Okay, one was around 5 centimeters, other side it was 2.5 centimeters. Bilateral recurrent chocolate cyst. So this was the finding. So what are you going to do? The basic investigations, I said everything is still normal limits. Male factor is normal. I have not done a CA 125. Instead, I did the AMH level, which was 6 nanograms earlier. It has come down to 3.77 nanograms. That is probably because of the previous surgery. So the male factor is normal. She is keen on getting relieved of her pain as well as fertility. So what is your next modality of treatment? Dr. Meera, would you like to take up this question?
Can we put her on leuprolide, ma'am, because she wants relief of pain also, and as well as she might just conceive during that treatment,
Leupride, anybody wants to add? Dr. Neelam, do you want to put her on Leupride because she's keen on pregnancy also? So if you are going to put her on Leupride, it is counterproductive. She is not going to conceive, but her pain will get
Yeah, before that, I will like to do her stimulation and preserve her, freeze her ova for pregnancy, further pregnancy. And we like to give her some adjuvant therapy, folic acid, low dose aspirin, and this dihydroepistrone and L-arginine. For
one point why I have put specifically dihydroepiandrosterone is you should not use the drug endometriosis because it is basically a estrogen dependent condition. Better you do not use this drug, and there is no literature evidence to show that it can increase the ovarian reserve, and it is a drug use it. So the thyroid supplementation she was getting, and as now let us see what the ESHRE guidelines says. So for assisted reproductive technology associated with endometriosis, especially if tubal function is compromised and if there is male fertility or other treatments have failed. So she fits into the category of other treatments like previous IUI has failed. So the choice of treatment for this particular patient is ART. So before going for ART, she has big endometriomas. You said that you will go for an ART, pick up the eggs, freeze, and then proceed with FUT. But sometimes we can get problems with oocyte pickup. So what are the things you can do? You can give Zoladex or Leupride. I personally prefer Zoladex because it is more potent than Leupride. So, but unfortunately, on doing a repeat scan, one ovary, the ovary that was having a smaller endometrioma has regressed, but the larger one, it was persisting. Now, what is your going to plan? Your plan is going to remain the same, or is it going to get altered? So this is again from ESHRE guideline, which says that GnRH agonist for a period of 3 to 6 months prior to ART will improve the pregnancy rates by 4-fold. So now
we can give one more injection of at least GnRH, and then we can go for ART procedures.
You want to go straight away for now? I am coming to
one more injection of Zoladex, at least 3 injections.
Now, what are the indications for surgery in recurrent endometrioma?
If the endometrioma is big, it is more than 4 centimeters. If follicles are not accessible during the
it becomes the most important cause.
Persistent pain is the most important cause. Most common cause. And when you suspect malignancy. And then other one is you should remove larger endometrioma after oocyte pickup prior to PT, because when you have associated endometriomas when the patient conceives during pregnancy, are you going to have adverse effects or not? Yes. No problem. That part of it will come later. Okay, so the recent study says that for infertile women, better than second line of surgery, IVF-ET is ideal. So how we are going to manage infertility in this particular patient? We have already. Dr. Sarkar, would you like to just put it in a nutshell? How will you manage in the event of recurrence? How will you go ahead?
Yes, the surgery has to be meticulous so that the antral follicles are not stripped off when we do a laparoscopy, and her AMH does not go down further. And as ESHRE guidelines suggest, we should give GnRH agonist for 3 months prior to planning of ART.
We have tried that 2 to 3 months. Since there was no reduction in the size of the endometrioma, then no other go. I have to go for a repeat surgery. So this is
repeat surgery.
Spontaneous pregnancy after first surgery is around 41%. See, don't think that every patient with endometriosis needs ART. Just with a simple, proper surgical correction of endometriosis, most of the patients, they do conceive, and it is somewhere nearly 40% of the patients, they conceive spontaneously. But with after 2 second surgery, the incidence goes down to 23%. So this was the right endometriotic cystectomy was done in this particular patient, and there were a lot of additions, but instead of doing a cystectomy, I had just opened it and drained it and just released the additions. And hysteroscopy was not done in the previous surgical procedure, so I have to do it. So the patient, then she had another dose of Zoladex, and then this is again the recommendations by Yeshre saying that a larger endometrioma, when you do the surgery, there is no evidence to say that prior to treatment with ERT, you need to do it. Or even if you are going to do the surgery, it is not going to improve the ERT outcomes, only the endometriosis pain can get reduced. So we have to again counsel the patients regarding the oocyte ovarian reserve reduction. So after this, the patient had a basic hormone assay done and left antral count was good. The surgical on the side on which the endometrioma was resected was low. And which protocol you will prefer? Which protocol you will prefer, Dr. Meera? You want to go? This patient has already received a long depose previously.
I think infertility specialist will answer better. Devashish will answer.
FSH 150 heavy doses of FSH for 5 days, and on day 6 E2 should be done. Then if it is
so this was E2 was quite good, and again continue. You prefer an antac cycle or an agonistic cycle, Doctor?
Since we are already giving a depot, we can go for a down-regulated cycle. And per se there is no difference in down-regulation and antac cycle as far as the results are concerned.
Yes.
Since we are therapeutically giving Zoladex, we can always start stimulation in a down-regulated protocol.
She was given after that, last 5 days we had added antac, and trigger was given with the recombinant HCG. And see, the most important thing is, suppose if you have a endometrioma, when you are going to do a oocyte pickup, what are the precautions would you like to take? Any infertility consultant can take. What are the precautions would you like to take when you do the oocyte pickup in these patients?
As far as possible, we should avoid pricking the endometrioma, and if we at all need to aspirate it, then once the OPU is done, then later on we might think about touching the endometrioma.
We have to take a precaution. She should not get infected because there may be formation of the abscess, ovarian abscess. So we have to give precautionary antibiotic to this patient.
You are rightly pointed out.
All septic precautions should be taken while doing the aspiration of eggs.
Anybody is for routine aspiration of endometrioma?
No, as far as possible, we should avoid it during oocyte pickup. And if at all, then once the OPU is complete, then at last we should think about aspirating.
What about Neelam, madam? Would you like to, even after completion of the oocyte pickup, you do want to go for aspiration?
Why should we do that?
Mostly we should avoid it.
I will not do.
It's always better to avoid transvaginal aspiration of endometrioma.
Yes.
If at all you want, after completion of the oocyte pickup,
completion of the OPU, then we can
laparoscopy, and then you correct it, then before endometrial transfer. So this patient was very lucky. She had 11 oocytes, 7 were M2, ICSI done, 6 did Day 3, I transferred on the same cycle, and 3 blasts were frozen, and her beta HCG was 232, and she had a lovely single child, and single sac I could see on the 6th week, and everything was going on very smoothly. 20 weeks scan was normal, but there was some evidence of high resistant flow in both uterine arteries, and hence I continued with organoitric and aspirin. At this juncture, I would like anybody to take up this question. What are the impacts of endometriosis on pregnancy? See, once a woman becomes pregnant, are you happy with that, or you need to have a more vigilance upon this page?
She can end up in abortion. So we have got to follow her up for that.
Yes.
Abortion is very high. Then in
Yes.
the first
luteal phase defect in this patient most because they are all antagonists, so they get luteal phase defect. So we have to support with the progesterone in this
patient.
So that is for prevention of abortion. Anything else in the first trimester? Any other complication?
We have to see the other. We have to go for other tests like APLA and APTT for the
times.
Generally, I personally do it prior to ART cycles. See, ectopic pregnancy is very high.
Ectopic pregnancy is high, yes.
So there was a very large study by Lucky Saraswat that was presented in Eshe 2015, I believe. I think it is in 2015, where they quote that the incidence of ectopic pregnancy is sometimes threefold. So this patient was, and then anything else? What about the placental factors in this particular patient? Do you think that placentation is the same as that in the non-pregnant patient, as a non-endometriotic patient?
No, there will be high incidence of antepartum hemorrhage, low-lying placentas, and morbidly adherent placentas would be there.
Yes, you are absolutely correct. The incidence of low-lying placenta previa and abruptio placenta are very high because of partial remodeling of the placentation. So this intrauterine growth retardation is also likely to have. So again, the patient was followed up till 34 weeks. Everything's going on smooth. At 36 weeks or 37 weeks, I think she came with complaints of reduced fetal movements. So that one simple thing we have to tell the patient. Whenever she has reduced fetal movements, she has to hurry up. And the ultrasound showed and
less.
Now the patient was immediately posted for LSCS and she had a baby weighing 2.3 kg. She was very happy. And then now she is waiting for the other embryos are there with us and we are planning for a FET sooner. So now these complications, I think we have managed in early pregnancy, miscarriage, ectopic, late pregnancy, antepartum hemorrhage, hypertension, preterm labor is very common, increased risk of C-section, stillbirth, and two important things anybody can take up this. What is spontaneous hemoperitoneum in pregnancy that is common in endometriosis? Otherwise, I will tell you. See, in patients with endometriosis, when they do conceive, there may be some vessels that bleed. See, all these vessels are all decidualized, where there is thinning of the walls of these vessels. So they can rupture and cause spontaneous hemoperitoneum. And in the literature evidence, there are a lot of cases that has been described. And last week, I had a same panel with Dr. Atul Ganetra, and he was also pointing out one of his patients who had a spontaneous hemoperitoneum. And the next one is bowel injuries. Spontaneous bowel perforation is also very common because, again, when during pregnancy, these bowels, they get stretched out because of the previous additions, or many of the patients can have bowel endometriosis. That is also one reason. So a patient who becomes pregnant following endometriosis treatment has to be monitored very carefully. So, so I think this we have. So this is again, I said, does this patient, she says, I have undergone repeated ovarian stimulation with IUI. I said the chances of recurrence are high. If the same patient has undergone repeated IVF procedures, do you think what is going to be her chance of recurrence? Is it the same? Is it going to be high or is it going to be less?
Be higher.
It's the same.
See, in its literature evidence says pre-ovulatory aspiration of follicles in IVF may not increase the chance of recurrence. So that is the main differentiating point, because in IUI, what do? We allow for spontaneous ovulation. Spontaneous repeated multiple ovulations are going to induce endometrioma. But whereas when you aspirate, the chances of endometrioma recurrence is going to be low. So ultimately, when a patient with endometriosis and infertility comes to you, this is by Chaperon in 2000, this was by 2016. I had the opportunity of spending few days with Professor Chaperon in Asia Pacific meet where we were only few people who had 3 days of discussion with him. In the initial meet, he suggested endometriosis to be diagnosed, medical management, unique surgery, go for ART and continue the medical management to prevent the recurrence. But when I recently met him in Taiwan in 2019, the protocol has totally changed. He says, once when you think about the endometriosis, just by the symptom, you start the patient on medical management, and when she desires pregnancy, till then continue the medical management. And these people are very fond of Diniges. They continue till the girl wants to become pregnant and immediately switch over to ART and then again continue the medical management. This is the latest protocol what they are following. But personally, I feel in our setup, maybe we can have some amount of surgical correction also, because that can improve the spontaneous conception rate. So now the take-home message, each one rapid fire take-home message.
Yes. In endometriosis, infertility should be managed by ART.
Repeated surgery should be only for large endometrium and should be avoided at OPUs.
Yes.
And FET should be done.
Okay. Meera was telling
avoid repeated IUIs and just go for ART, especially the IVF.
Then, Meera, you were so much talking about counseling. Counseling regarding the reduction in ovarian discharge should be discussed, and oocyte pickup followed by FET. That gives the best result. Preferably, do not transfer in the same cycle. Preferably, FET is ideal, that too in the natural cycles. And GnRH analogs given prior to FET increases the odds of pregnancy rate by 4-fold. And pregnancy following endometriosis should be treated as a high-risk pregnancy. Okay, then moving on to the case number 3. Mrs. P, age 24 years, complaints of dyspareunia, dysphagia, known case of deep endometriosis since the age of 18 years. Here only I am saying 30% of the girls, adolescent girls, can have stage 3 or stage 4 endometriosis. She was put on medical management. When she came to me at the age of 18 years, I suspected endometriosis, and actually when I did an examination, she was complaining of some irregular spotting. When examination and under anesthesia was done, I could see a posterior lip endometriosis, which I had excised. Okay, then after that, she was put on GnRH, Diniges, COCs. See, she was not that much affordable. So I had to put her on. Some initially started with GnRH, then followed by Diniges, and after that, she wanted to take only continuous COCs. Now, my question is there a role for gabergolin in these patients? Anybody has tried gabergolin?
लड़के की वही
Dr. Anju, are you there?
हाँ नहीं लड़के की लिए चाहिए
Meera?
No, ma'am, not gabergolin.
Not gabergolin. Neelam, madam?
We can give tamoxifen instead of gabergolin. Tamoxifen can be given.
See, actually, gabergolin is a very good drug. You know, the action of gabergolin is it suppresses VEGF. Okay. VEGF is highly overexpressed in deeply infiltrative lesions, superficial lesions of superficial peritoneal lesion, where you can see the active vascular changes. So, when you compare the cost, gabergolin, you need not take it daily, and the cost is low. So, for this girl, it was the initial phase. I tried her with gabergolin. She was doing excellent. So, there was again, when there was an evidence of deeply infiltrative lesion at the age of 18 years, then at age of 24, she got married. She came back to me with complaints of dyspareunia and dysphagia. Now, how are you going to manage?
We will see her, we get her investigated and see her CA125 and all the marker, FSH, LH, AMH, everything, and ultrasound, of course, about any endometriosis, any endometrioma or size of the uterus, if there is any evidence of adenomyosis of the uterus because she's having so much pain. So she may be having adenomyosis also along with that. All these things to be ruled out, and because she is already in the management, so medical management. So if the patient is asymptomatic, she may not need surgery, and there is a high risk of unnecessary bladder and bowel injury. You can direct take her for the trial of stimulation, first by 3 IUI cycle, and if not, then IVF cycle.
But this patient was having severe dysmenorrhea and dyspareunia. So MRI was done, which showed a nodule in the pouch of Douglas around 3 to 4 centimeters. So it's not only the question of fertility, what she wants, but it is also the question of pain relief. So this patient I had taken up for surgery because she was symptomatic, and if she is asymptomatic, like you have told me, that I will take up earlier for an ovulation induction with IUI. But in this particular patient, I had taken up for surgery. After seeing the MRI, there was no bladder involvement, only the lesion was confined to the pouch of Douglas. Okay, so how will you counsel her before this procedures? This is what I said. There is this woman suffers from pain requiring surgical treatment. And then precautions to be taken during surgery, because deeply infiltrative endometriosis is something what
surgeon with you, and we have to take the proper while doing the surgery.
So MRI was done, and with the multidisciplinary team approach and with the detailed counseling, she has undergone the surgery. So this was the nodule which was in the pouch of Douglas. You can see the ovarian ligament and the uterosacral ligament. Everything was pulled down. And finally, actually, we had dissected extremely, up to the vaginal wall, and the medial portion of the uterosacral ligament was also excised. And she subsequently, she came back after 2 months because I need to plan her for a ovulation induction, as she was keen on fertility. So how will you evaluation of the male factor, hormonal assay, everything was normal. So as rightly you have pointed out, I took her for a ovulation induction with IUI. I was planning, started her with letrozole and HMG. But on the 9th day when she came, she had 5 to 6 follicles on either side. So it was an hyperstimulated ovary. So emergency IVF, I converted. So that is the possibility. One thing is whether you need to go for emergency IVF or you cancel the cycle. So she had 8 eggs, developed 6 good embryos. She was transferred 2 embryos in the subsequent FET cycles, and she had a single-time baby delivered at 39 weeks. So the LSC was done as it was. So there are studies to say post-operative fertility rate in deep endometriosis can be improved either by spontaneous conception or by doing an ART. But you should not do it per se for treatment of fertility. Okay, only when the patient has pain, you do it. Otherwise, you do not touch the patient because it's going to harm her. So finally, I will finish with this case because I can see Kavita Papat waiting for the next AUB panel. So one take-home message from this particular case.
If there is a deep endometriosis, size is big and it is causing pain, it should be operated before going for ART.
Surgery is indicated when medical
Golem is indicated in cases of deep seated endometriosis.
Okay, so I finish with this. Dr. Sarkar, do you want to add anything else?
Yes, the incidence, as you had discussed, it is quite high of deep infiltrating endometriosis in adolescents is around 30%. And surgery should not be the primary modality. Okay.
So ART can finally improve the fertility. I now thank my panelists for the, for a very nice answers they have brought about. And I thank Priyanka and Indranil and Nikarika for giving me this opportunity. Thank you all.
Thank you. Thank you.
I thank the panelists and Ramani Devi ma'am for an excellent panel. It was really very informative, and we had an excellent discussion, and of course we learned a lot from this panel. Thank you so much, ma'am, for doing this panel with us, ma'am. Next, moving on to the next panel, but before that, I would request our guest of honor, Dr. Bhaskar Pal sir. Sir could not join us before because he had another session. So kindly to share a few words with us, and after that, we will move on to the next panel discussion.
Thank you, Indranil and Priyankur. Am I audible?
Yes, sir, you're audible, sir.
Yes.
Yeah. Thank you, Indranil and Priyankur and Niharika for inviting me. You all are doing great programs and you've got stalwarts. You've got the Endometriosis Lady of India to conduct the panel on endometriosis. And you've got the daycare vaginal hysterectomy lady to do the panel on abnormal uterine bleeding. I think what is very important is that webinars are the way forward. And I think what we've learned from the pandemic is, yes, we cannot meet at the present moment. That is a problem. We are missing the networking, the fellowship that we have during the conferences. But what has happened, the good side of the webinar is that, number one, it has made education more equitable. You don't have to travel, you don't have to pay to go and listen to great speakers. That is number one. And the second point is that our attention span has increased. We sit through lectures much longer rather than going out to have a cup of coffee and go or visit the exhibition or to chat with somebody. So I think we are making great use of the webinar, and well done, the young duo of Indranil and Priyankur, and I wish the rest of the program a great success. Thank you.
Thank you so much, sir, for your kind words and for your message and for the encouragement, sir. It's really, as you said, aptly said, we still at 8 o'clock in the evening, we still have more than 1,300 people who are there viewing this webinar. So it's definitely a great attendance and definitely people are interested to go ahead with the second panel, that is AUB. But before that, just a short notice, I would like to congratulate or rather I would like to wish all the best to my friend Indranil for his election for the Clinical Obstetrics Committee. And I see also my other friends, Nilesh, who's there for the Quiz Committee, Subhash, who's there for the Endoscopy Committee, and Saijas, who's there for the Midlife Committee. All the best. And Nisha Singh ma'am, she's also there with us for the next panel, and ma'am is there for the Oncology Committee, and I wish ma'am all the best too. So moving on with the next panel discussion, I would first like to invite the first chairperson for the next panel, and that is Dr. Preeti Kumar ma'am. So I request Sana to please play the slide. Yeah, Preeti Kumar ma'am, again, everyone knows her and everyone knows her more vividly now, right after the super success of AICOG last year. And it was an excellent program, ma'am, and we still talk about Lucknow AICOG and Lucknow food, basically. So it was awesome, ma'am. So she's the director of Sunflower Medical Center in Lucknow, chairperson of Safe Motherhood Committee, FOXY, fellow of ICOG, vice president, Lucknow Obs-Gynae Society, past vice president of the Association of Private Gynecologists, organizing secretary of AICOG. She has received a number of awards. She has been felicitated by MSD for Mothers for outstanding service for FIGO in Rio, recipient of the FOXY Imaging Sciences Award in 2004, regional faculty for GDM.
Thank you so much. We are already.
Sorry, yes, ma'am.
Thank you for your kind words. I understand when you are too late in the session, then other panelists and moderators, they are to go ahead with the session. So thank you so much for kind words. And I really appreciate the way you are conducting this. All the young brigade, especially congratulations to Niharika. Indranil, you are doing great job. Priyankur, you are also a very active member of FOXY and you are also doing a great work. Excellent panel by Dr. Ramini Devi, madam. Thank you so much, madam, for putting such nice insight about the endometriosis. I was there right from the beginning, and the panelists also did the great job. Thank you so much, everyone. I'll not waste much time, but few words about Dr. Kavita Bapat, who is the next moderator. I love her very much because I really appreciate and admire her, the way she lives and the way she inspires everyone. Thank you, Dr. Kavita ji, and wish all the good luck to all the panelists and all the members who are contesting for the post. So I'll not waste much time, and I request the moderator, Dr. Kavita, to please proceed.
Yes. Should I proceed? Can I share the screen? Thank you so much, Preeti madam. Niharika, can I share the screen?
Yeah. Niharika,
Yes, ma'am, I'm here, ma'am.
Okay, can I share the screen, no? Okay.
Yes,
Yeah,
ma'am.
sure, ma'am.
Yes.
You can, ma'am.
Okay. So, thank you so much, Preeti madam, for kind words. The panel being given to me is abnormal uterine bleeding. First of all, I respected Atul Ganatra sir, Dr. Bhaskar Pal and Dr. Ramani Devi as a the sitting vice president as well as a past vice president Bhaskar Pal. And young promotion committee, thank you so much that Niharika, Indranil, Priyankur, all are young because Niharika is just like my another daughter and I just love her. She's very favorite of me, and Indranil, Priyankur, and you are making hit. You are becoming viral nowadays with each and everything. So all the best to Indranil, Shaizas, Subhash, all males. It's too much. So all the best to my topics today. It's abnormal uterine bleeding, and I will not include a single word over here about endometriosis because it's already been covered. So, and the first of all, I'm happy to tell all of you that I'm from Indore, and the fourth time our city has been declared as the cleanest city of India. I'm really, really proud for that. So again, congratulations to myself. Thank you so much. Now the point is, important point, these are my esteemed panelists because they have not been introduced. So it's my responsibility to introduce them. I think anything left, so please mujhe maaf karna. Uma Pandey, President Varanasi OBGYN, Alka Sethi, Secretary of Jhansi OBGYN, Anita Chhabria, Joint Secretary Bareilly OBGYN Society, Sujata Bhatt, President Noida OBGYN Society, Nisha Singh, Secretary Lucknow OBGYN Society, and Dr. Bharat Prasad, President Darbhanga OBGYN Society. Priyankur, anybody left or you want to add anyone, let me know. So that
no, ma'am, everyone is there, ma'am. Only one thing is Dr. Bharat is not there because of some family problem. His brother passed away yesterday. So
Okay.
other than that, we have everyone with us.
Okay. I just want one thing, Priyankur, that everybody should mute. Only my panelists should be unmute. So that
Yes, I'll
be able to conduct the panel in a better manner. Okay. So it's a very simple thing. And I'm just asking all my esteemed panelists are just to answer in a 1 or 2 sentences. Don't spend much more time in discussing anything. Just make it, and that point should be a take-home message sort of thing. Not like that we are discussing or theory or something. It's a day-to-day problem, and every day we deal with it. So it's AUB. It's a very close to heart my subject, and in India, the 90% of the cases of AUB end up into the hysterectomy. So I am really, really nowadays worried. Rather than promoting a hysterectomy, I am saying how to save the uterus is another agenda by this. So the number 1 case, Mrs. X, age 34 years, she is para 2. She came with a history of heavy menstrual bleeding since 7 months, delivered 8 months back. The weight is 43 kg. BMI is 19 square meter and pallor is 6.8 gram, rest NAD. So my first question to Dr. Alka Sethi is there? Dr. Alka?
Yes, thank you, Dr. Kavita.
Yes. Please, Alka madam.
This is one of the case of post-delivery bleeding. So usually when there is lactation, then menstruals don't occur, but due to some reason, first of all, she must be anemic, and we have to take proper history, her general history, obstetric history, everything we have to take, whether it was a normal delivery or cesarean, or
So
she had any instrumentation.
Just आप 5 point बताएं कि what history points you are concerned about this patient. Only the history points which you are concerned about this patient.
Yes, whether she had a prolonged labor, her type of labor, instrumental delivery, whether it was normal or cesarean, she had any puerperal sepsis, she had PPH, any of these problems, whether she had or not.
Okay. Are you not worried about her weight? Are you not worried about her BMI?
Yes, that is also more. So she's more on the weaker side. That is why she must be anemic, and that is why she must have bled, and this could be the cause of bleeding even now, which will worsen her condition. So
okay, in a history, Dr. Uma, will you like to? Uma is there? Dr. Uma Pandey?
Yes, ma'am, I'm here.
Okay, Uma, are you there? In a history, do you like other than delivery, the history of obstetric history, gynec history, any other history point which you want to add into this case?
Actually, to be honest with you, madam, I'm very worried about this lady.
Yeah, yes.
She's 34. She has 2 children. That is fine. She has history of heavy menstrual bleeding since 7 months. So she delivered 8 months. Just after 1 month, she started to bleed heavy bleeding. Her weight is also 43. Her hemoglobin is very low. BMI is low. So maybe we need to think about molar pregnancy or postpartum placental polyp or some other coagulation abnormalities which this woman might have.
Are you not worried about some thyroid, diabetic, this medical problems? Anything which you want to add in the history in this patient?
Yes, ma'am. Usually, if she is underweight, she would be hyperthyroid. Usually, I'm talking about, ma'am, I'm not contradicting you, but then she would be hyperthyroid. Hyperthyroid usually does present with amenorrhea, but yes, it can present with hypermenorrhea. And diabetes, yes, diabetes.
You want to add anything in a history? Dr. Alka has rightly said she will find it out, all the obstetric history, all the gynec history, previous history, prolonged labor. Uma has Uma talked about all the things about the polyp, the placenta, or the gestational. You can say about.
Excuse me, could I just add a point?
Sujata, I am coming to you. Sujata, I am coming to you. Anisha, please.
Yeah. Yeah. Since she has delivered, I want to know, was an IUCD put in, at the time of delivery? Is it an iatrogenic, this thing, because of the IUCD she is having? Apart from that, of course, we covered the hormonal causes, the thyroid and, dystonia. Any anticoagulant she is taking because of some other disease that is.
So the history is, Dr. Sujata, you want to add something? Yes, Dr. Sujata.
Nowadays, the current discussion is on this condition called cesarean niche, which causes heavy bleeding post 2 cesareans and such things. And because the cesarean rates are very high, was this a case of previous 2 cesareans? Because we should think of cesarean niche.
Okay, so you just it will come into the history of the obstetric history. It will come. You mean no? I'm clearing. We are going to get a take-home message. Don't stick onto the case, because what take-home message we are going to give all of the audience is we'll take a proper history which includes the obstetric history, the gynec history, and all the medical history and all the history of the contraception and all the history of urine pregnancy test. Will you do it, Uma?
Yes, madam. I would like to do it in the outpatients, and also tuberculosis. I was kind of into
diabetes, thyroid, tuberculosis, coagulopathy, and what about the another history which we are talking about, the contraception? And so because
cesarean history.
Yeah. Anybody, Sujata, Anita, are you there? Anita Chabaria?
Yes, ma'am.
Yeah, please. Can you add anything, Anita?
Ma'am, I would also rule out chronic endometritis post-delivery.
Okay. There can be chances. So how, by taking history of fever or anything like that?
Yes, ma'am, we can take a history of fever or we can do an ultrasound and see. And we can also, if we do not see anything on ultrasound, on transvaginal ultrasound, we can also send a vaginal swab and do a trans endometrial aspirate and see what is there.
See, we have not gone up to the examination of the patient. We are strict and we are here with a history point. So you will take the history point of this fever and everything over this case?
Yes.
Okay. Yes. We all are worried about the weight of this patient. BMI is very low and hemoglobin is 6.8 gram. Am I right? We are not making any conclusion of this patient. Just try to make it point. So the first case is take-home message is a right history is very, very important. So I'm not telling you what we did and what I have done and what I have managed this case. So the best thing, 2 things is the number 1 is the history. And if nothing is there in this patient and the transvaginal sonography is normal, the PS is normal, everything is normal. So the 2 points which I want to ask you, does this patient need a medical management or a surgical management? Only 1 line answer. Anita?
Medical management.
Alkaji, which type of management you will want?
Supportive iron therapy, if not, if her hemoglobin is also very less.
Or a surgical management. Madam, सिर्फ 2 बात में से medical management or a surgical management?
Medical management first.
Manisha, आपका? Medical management?
Medical, if the TVS is normal, if everything is normal,
Yes, medical. Okay, with the history part. And Uma, with you also the medical management in this case?
Absolutely, she needs medical.
Okay. So after taking a good history of this patient, what is the next thing which you like to do in this patient? For examination, what points you like to see in this type of patient? See, because these panels are to make people aware of the things, not of the only this case. This is the one of the case only. So what examination point you will like to see? Right from you start with Alka madam, just tell me what points you would like to see in the examination.
We'll do a CBC and blood count, everything.
We are doing simple examination, madam, not investigations. I am talking about the just examination of the patient.
Examination, the general condition and local examination also.
Yes.
Whether there's any bicornuate uterus or any other abnormality, or because she's bleeding, still she's having heavy bleeding, so she could. But TB ultrasound is normal, so.
Okay, you will include ultrasound into the examination, no problem. Anything like to do PS or the cervical smear or something like that? Anybody will want to add into it?
Yes, there could be a cervical polyp.
Sujata.
There could be a cervical polyp.
Okay, okay. So you will do
the PS is very important.
TB examination to exclude the cervical. Whenever we have a case of AUB, we should be thinking about all the causes of AUB with the palm coin. Am I right? And we are excluding one cause, another cause, any cause, and the medical management or the treatment. So this is the first case we are talking about. So you did the right history, you did the right examination, you did the things. Now, this is the second case. Second case is she is a 45 years, para-2, obese, BMI 30, diabetic, hypertensive, heavy menstrual bleeding since 2 years, Pelor 2+, pulse 96, BP 115/100, sugar FBS is 402 and postprandial blood sugar is 588, and HbA1c is 10. She is a 45 years of the age. This type of patient comes to us with all the history. Now what is the management? I'm talking about the single type of management, surgical or the medical. Start from Anita.
Ma'am, we will do endometrial aspirate will be my first thing with a pap smear.
Okay, first the endometrial aspirate and the pap smear. Okay.
And the transvaginal ultrasound.
Okay. Alka ji, aap?
I'll prefer medical management first. Take care of the diabetes. Take care of. I'll do her thyroid profile also, and I'll prefer to control her sugar first and the anemia also, because she has a lot of pallor. So first I'll do medical management, and then I'll go in for the
Dr. Nisha.
Yeah, this patient has all risk factors for endometrial hyperplasia and malignancy. So on clinical examination and TVS, if we do not have any structural anomaly, then definitely an endometrial biopsy is required. And if I have the hysteroscopic evaluation along with that, I'll be happy with that. Because, yeah, of course, controlling these things simultaneously so that, we have all care for the.
For the endometrial factors, all these are the risk factors, having a diabetic, having the hypertension. Are you okay for the endometrial factor of the AUB palm coin? You're worried about all these factors, and especially obesity is also there. So she is one of the case which we can think about a endometrial factor of AUB. Am I right? Okay. Yeah. Anything, Uma, you want to do in this case? Hysteroscopic evaluation. Endometrial biopsy.
As Dr. Alka has rightly said, we have to control the sugar, because this high level of sugar could be dangerous for her. And once we have controlled the sugar, yes, I would like to go ahead with hysteroscopy plus endometrial biopsy and get the result of the biopsy and manage the case according to the biopsy report.
And Sujata, you want to add something else other than these points? All of them said.
They're all independent risk factors for endometrial problems and hysteroscopy and biopsy after optimizing her medical condition.
Okay. So the first case was simple. We just worried about all the history part. This case, because we know most of the history and we are worried about what is the cause of AUB. So we'll exclude. The exclusion technique is better for diagnosing rather than blaming her that she is having this thing. Okay. On sonography, uterus is bulky, 6 to 8 week size, endometrial thickness 12 mm. Am I right? So she was a case of endometrial part. Okay, and we are able to do it. So now that she is a case, I'm only dealing with four cases and very simple one. She is a 43 years. I am talking about all 3 cases which are 43, 44, and they come to our clinic and we are really in a dilemma to do the surgical management or to do the medical management. So how we exclude all those things are very, very important. So she is a para 3, complaint of severe white discharge, eating 6 years and wants hysterectomy. So and having a taking medication from different doctors, now fed up. So don't take it, this is a case of AUB, don't take it in another way. But this type of patients come to us day to day and having a history, probably the one line is missing over there, having a heavy menstrual bleeding. So what is your opinion regarding this, Anita? It comes like this. They go from one doctor to another to another. She must have gone to 5 doctors. Now she has come to you, Anita. What you will suggest to this patient?
Ma'am, after seeing the general condition of the patient, I would like to take a history of sugar. If she has done it previously, any sugars have been done. If not, I'll do it. I'll do a per speculum examination. In my OPD, blood sugar is done for such type of patients as soon as they come. And then I'll do a per speculum examination and see the type of discharge and whether any cervical lesion is there, whether there's an ectropion or it is just a simple fungal discharge, and the history suggests that. And
so you will do the PV per speculum examination and do the pap smear for this patient?
Yes, ma'am.
Although she has been
after pap smear will be done, madam, after once I give her something for the fungus, fungal something to relieve her of the symptoms. Later after it,
Alka madam, she has come after the Anita madam to you that कि मैं अनीता छाबरिया मैडम के पास गई थी और मेरा पेप स्मीयर नॉर्मल है, but मैं I am really worried about कि मुझे नहीं जम रहा है. So what you will suggest her?
I can take a wet preparation to see the organism and then gradually treat her according to that. And diabetes, of course, must be there, so has to be controlled. Sugar is very important.
Okay.
And,
Okay. Anisha, what you will do?
I just wanted to add, like for abnormal uterine bleeding, chlamydial infections sometimes are the cause of the bleeding, and these symptoms are very much suggestive of that. So,
correct. So there is one line missing of heavy menstrual bleeding. I'm extremely sorry for that. She is having a parathormone complaint of severe white discharge as well as heavy menstrual bleeding.
So that
in which AUB palm coin में which category it comes? If white discharge and the per speculum examination, for example, it has been some negative report with a pap smear, then what you will suggest? Will you do the colposcopy if the patient's report is some CIN1 or CIN2, or you won't do it?
No, if it is coming CIN1 or on the pap smear, then depending upon, she is 43 years, and if the pap smear is showing LCIL and above, then definitely she has to go for a colposcopy.
Okay. Uma, will you want to add anything? Unmute yourself, please.
Yes, madam. Whatever has been said, I would just like to add that these kind of severe white discharge is common in women who have candidial infection, as rightly mentioned by Dr. Alka, that and Dr. Archana, that we would do sugar. And if she is negative for sugar, even then some people have potential or predisposition to have repeated recurrent candidial infection. They should be counseled regarding that. And obviously we have done past, somebody has done wet mount, somebody has taken pap smear examination, CIN1 for 2, we have thought of colposcopy examination, but a long-term treatment of candidial infection is also very relevant in this case because it can be very disabling for the woman.
She's already also having the heavy menstrual bleeding. Sujata, what type of counseling this patient needs? If she comes to you after these 4 gynecologists.
No, I will still say there are a lot of medical options which she still hasn't gone through. You don't have to go through surgery yet. Everything has not been tried.
So all 5 are ready to say that she doesn't need surgery. Does she need surgery, Sujata? Yes or no?
No. We can still investigate and try everything.
Uma, does she need surgery?
She may have left sclerosis. which needs to be examined and biopsied if there is a doubt about that. It is common in a woman with diabetes and it leads to intense itching.
Nisha, are you for the surgery?
No, I just want to say that 40 plus women and not having any structural again and endometrial biopsy, still I would, go in favor.
Yes, HMB.
Okay. Alka madam, आप surgery करेंगे?
No, I'll treat both the partners. Should be treated, counseled, and I'm about saving the uterus. I would not like to.
Okay, good job.
I'm of that.
Anita, will you like to do?
Madam, I will also do viral markers for her. I'll do an HIV for her, and I'll also give anti-fungal treatment to the husband and do husband's sugar also. He might repeatedly giving her infection.
So any cervical lesion should be excluded. It's a palm coin with the C that point has come. Now she is a 44 years, complaint of bleeding per vagina and continuous spotting for 2 months with a history of medical abortion 3 months back. Now what investigations will we do? Right, Sujata, start.
44-year-old bleeding per continuous spotting. With history of medical abortion 3 months back.
Yes.
So we do a transvaginal to make sure there is no retained small little bit or a polyp inside the uterus. Look at the pars speculum also and rule out any polyp at the cervical area. And do a beta HCG to make sure there is no connection with gestational trophoblastic disease. And if all those indicate that there's nothing wrong, then we treat her medically.
Okay, so you mean you will do transvaginal sonography, pars speculum examination, and find out and rule out. Uma, any investigation will you like to do in this type of patient?
I think Madam has rightly done beta HCG. She has also done ultrasound examination and a speculum examination. That must rule out whether there is a persistent retained products of conception or it's not there. If it's not there and but there is a history of continuous spotting, then she must be investigated for cervical lesion later on. Plasmid examination, colposcopic examination. On that line, hysteroscopy may be required if there is a polyp. All those things has to be done once this is sorted. This investigation.
Anisha, what is your approach for this patient?
I think it's similar, because first I have to rule out that retained products, and then after that, all other parameters for any 44-year-old woman, as I said in the previous case also, CVS, and then the endometrial thickness, ruling out adenomyosis, myomas, and endometrial causes still has to be done in this case.
Correct. Alka, same with you?
Yes, almost same. Coagulation profile can be done, but hardly any use. Coagulation profile can be done.
Why you need coagulation profile in this case?
No, in case if nothing is found, then anything is possible after
on the first go you will do the coagulation profile.
No.
You will do after
no, if she's not relieved with all this, if nothing positive is there, then I may go.
I'll go. Anita, anything and you want to add?
Ma'am, blood examinations, a complete blood count will be done along with this, and a thyroid and a sugar.
So that's really good. Now this is the case 5. She is 35, history of severe menstrual bleeding lasting more than 26 days. On examination, uterus 6 week size, endometrial thickness 10 mm, simple ovarian cyst of 3 into 4 centimeter of size. Patient, my goodness. Hello, am I? Dikh raha hai? Am I audible?
Yeah.
Case 5. No. Okay. So, so what is going on? So she's a patient is panically worried about cancer. So what's our approach to this patient? Start from Sujata. Dr. Sujata?
Yeah, so they've written endometrial thickness 10 millimeters, but which phase of the cycle? Because it could be a polyp if it is in the early phase of the cycle. But lasting for more than 26 days, then she's free of bleeding only for 4 days or something.
Bleeding lasting for 26 days. The patient comes like this, no? कि पूरे महीना bleeding हो रहा है.
So then we should know whether really how many pads is she changing to know whether what she is saying is heavy.
You are worried about her bleeding part, no? Bleeding part you are worried about, and which cycle of the which part. Patient normally comes with us, no? History of severe menstrual bleeding lasting.
So we should know how many pads she changes in those last 15 days. whether it's just half a pad and then she thinks it is severe, even in after the first 5 days of severe bleeding. So we need to get a proper history of the number of pads she changes even on day 26 to know why she says 26 days.
So the history is very, very important in this case. Am I right? Yes.
Yes.
Dr. Uma, what is another important thing in this case? History is always important. Yep.
Yeah. No doubt history is very important.
Yes. You won't do the urine pregnancy test, Sujata, in this case? Nisha, are you going to do the urine pregnancy test?
Actually, I was going to ask, is there a history of preceding amenorrhea? Because the incomplete...
So the history is very important. Yes.
So urine pregnancy test, yes, I will like to do this.
Yes, you will like to do, no? Because she is continuously bleeding, we just don't know the history of anything. Anita, will you like to add something?
Yes, ma'am. I would like to know her, after doing a pregnancy test, I would also like to know her contraceptive history, because the females, they keep taking centromin and then they have endometrial thickness increasing and then shed off bleeding continuing like this. They come to the OPD that they have been taking Saheli for some 6 months and 4 months or 3 months and then they are bleeding like this.
Excellent, excellent. Yeah. You're worried about, and then the perspectival examination about all the cervical and
yes.
And what will you do, all appointed. Now I'm just concluding everything because all of us know many more things in the AUB. It's not a tough thing. But whenever the patients of the AUB comes, we should, with the new definitions, we should be do with the history and all things. So again, the polyp, adenomyosis, leiomyoma, malignancy and hyperplasia should be in our mind. It's a structural one, and the functional one, the coagulopathy, ovulation dysfunction, endometrial, iatrogenic, not otherwise. I just want to go back to the case. In any case, we have to find out if there is a polyp, if there is endometriosis with a history, again with the leiomyoma, and these are the definite sub-classifications of all these things. So, AUB has become a very good subject if it has been properly managed and with a good algorithm it should go. So I'm just telling you a simple algorithm for any AUB case. So common cause is a palm coin, polyp, adenomyosis, leiomyoma, malignancy, and a dysfunctional endometrial, iatrogenic and not otherwise classified. Any patient who comes to us with a heavy menstrual bleeding, it's our responsibility to find out the bleeding disorders, menstrual history, family history of cancer, medications, pelvic and bimanual examination, each and every patient. And the number two is most important case. With the AUB, we are supposed to do the HCG for each and every case. So make it a point. Not for the panelists, esteemed panelists are already, you all have talked about SCG repeatedly, everyone. So it is in the mind. If it is negative, then we are not worried about the pregnancy part has been excluded. It is age less than 35 years and ovulatory cycle, sometimes negative patient this type of, or sometimes ovulatory patients. So CBC, TSH and prolactin is important. An abnormal elevated thyroid, hypothyroid, elevated prolactin, pituitary adenoma can be there. If a normal TSH and a prolactin, we are worried about the hyperandrogenism, obesity, consider PCOS and uncontrolled diabetes. And these type of also patients come to us with a heavy menstrual bleeding sometimes. And pelvic sonography is very, very important. EPM and more than 35 years and additional endometrial cancer factor. And ovulatory, again, all these tests, CBC, TSH and everything, activity, cofactor, and find out the things. The normal results, pelvic sonography, that's the line, and exclude the endometrial cancer factors. Abnormal results, abnormal coagulation, refer to hematology, elevated TSH, treat hypothyroidism. Now the patient is SCG negative, but she is more than 35 years. This type of patient come day to us. Check TSH, prolactin and EMP. This is the point. All labs. And then abnormal evaluation accordingly. SCG positive pregnancy etiology. These are the points. I'm just sorry for it. So all evaluation should be done properly whenever the patient, these are the history part as well as where we are proceeding for the AUB. And AUB is a day-to-day problem. I'm really, really happy to do. So take home message, everyone should, I think, will give me in a single sentence. That's very, very important. I'll start from Anita. Do we really exclude, should we do any abnormal bleeding patient who is more than 43 years of age comes to us, do we suggest hysterectomy to everyone or not?
No, ma'am.
No. Alka ji, aap?
No, I've never heard.
Nisha ji, aap?
Never.
Never. Uma? Dr. Uma?
It's indicated.
नहीं मैं तो
Sometimes.
बैठे बैठे क्या करती काम
And Dr. Sujata has gone ahead.
No, I'm there.
ये आपने नहीं खाई
Sujata, bolo.
बिना नमक की नहीं सिखवाई
And all we suggest is an endometrial biopsy and only proceed accordingly. And it's always medical management if the biopsy doesn't indicate any need for surgery.
Okay. So whenever the patients of AUB comes to us, the take-home message for all of us, I think all of you will agree that all bleeding patients after the age of 4 they need a complete evaluation right from history, examination, investigation, sonography, excluding one after another, and they should be treated well. Thank you so much, each and everyone. I think we did in a panel discussion in a different manner. Each cases were important to us, and this type of patient normally comes to us. That's the problem we all have. So SCG, the urine pregnancy test is very, very important in each and every case, right? Whenever this thing is to comes to us. Thank you so much, Priyankur. I think अभी introduction सबका कर दो एक slide दिखा के, because I have saved the time probably and saved the uterus too. Thank you so much.
Thank you.
Nice panel.
Wonderful panel.
Energetic panel, I must say.
Chris,
Enjoy it.
And I would like to share that till now almost 1,478 people are still logged in. So you have managed to keep the previous people also intact with us. So it was a wonderful panel, wonderfully moderated, and all the respected panelists were very prompt to their answers, and it was really good. And because it's going live in the YTP committee also, there is a lot of applaud in that Facebook this thing also.
Thank you so much. My panelists were extremely good, and they were similar thoughts of mine, so that our panel went very well. I just like the Sujata, Anita, Alka, Nisha, and Uma for giving your inputs. Thank you so much for being with me, and Priyankur and Indranil, you are doing the best. Thank you so much.
Thank you.
Before we finish, we should actually. I want to tell a few things about Niharika also. So Niharika is a very good friend of ours. She is the YTP committee chair, and she is very friendly. Whenever we tell her, Niharika, we want to do this thing, okay, you do it. So Niharika is very supportive. She is our youth leader at the moment, and he is guiding us in the correct direction. So basically, with this, we would like to have some words from our other chairperson, Priti ma'am, if you are there. Can you just wrap it up in a nice way? Ma'am, are you there?
Archana Verma madam is there.
Archana ma'am is there. I think Ramani madam is also there.
Ramani madam is there.
My God, really, Kavita, I want to say, Kavita, you did a very good job. Actually, the panel should be like this, like Dr. Ramani and Kavita has done, and Kavita has saved time. It was looking like like-minded panelists, no doubt about it. And with the panelists, good panelists, you can make a good guidelines.
Archana ji, Indranil अपने को बुढ़ा बोल रहा है. We are into the young brigade, Indranil. Take it a point.
Take it a point. We are good friend of Indranil now.
Thank you so much, everyone.
Thank you. So I think I will thank the sponsors, Mr. Sheshan, and for sponsoring this event. And really, we are thankful to Science Integra for this program. And with this, I think we can quit for the day.
It was record, na? Yeah, 1500.
Yeah, 1487 something. 1487.
Bye, Alka. Bye, Sujata.
Thankful to Bharat Serum Company.
Very nice panel.
Thank you. Bye.
Thank you. Very nice panel.
Best wishes to all the contestants.
Bye. Good day.
Thank you.